hand it over to Dr. Kate Lee. Kate is our Vice President of Research and Patient Programs, and she's going to introduce today's research speakers.
Thanks, Laurie. Good morning or afternoon, everyone. It's great to see so many of our volunteers here today, and I'm so happy to be here with you. We're so pleased to share Crohn's and Colitis Canada's funded research with you today. And thank you for volunteering to improve the lives of everyone affected by inflammatory bowel disease. Without your support, we would not be able to support any of the research projects, and including the two that will be presented to you today. There will be two presentations, as I said, each is 15 to 20 minutes long. If you have any questions, please ask them in the chat. There will be two Q&A sessions with our presenters, one after each research presentation. If we don't get around to your questions, please email us at volunteer@crohnsandcolitis.ca, and we'll make sure that a member of the team helps you out. So I'm pleased to introduce our first presenter, Dr. Karen Madsen. Dr. Madsen is a professor in the Faculty of Medicine and Dentistry at the University of Alberta. She is the director of the Center of Excellence for the Gastrointestinal Inflammation and Immunity Research. Dr. Madsen completed a bachelor's and a master's in biochemistry at the University of Manitoba, followed by a PhD in gastrointestinal physiology at the University of Calgary. She is a leading researcher in intestinal permeability and gut microbiota and their effects on disease and health. She works with clinical colleagues to test how therapies aimed at modulating the gut microbiome can influence metabolic and inflammatory diseases. Dr. Madsen is a member of the GEM project team and the National Imagine Chronic Disease Network. She is a member of the Women's and Children's Health Research Institute in Edmonton and the Digestive Health Strategic Clinical Network. She is the University of Alberta lead for the National Microbiome Research Corps. And with that introduction, over to you, Dr. Madsen.
Great. Thank you very much, Kate. I'm just going to start my slideshow here. I just wanted to add my thanks to all the volunteers for everything that you do. I've been involved with Crohn's and colitis for the past 20 odd years, and just seeing the progress that has evolved over that time and has really been spearheaded by research through the Crohn's and Colitis Foundation. The GEM project is really exciting, and there is so much research coming from that that's going to affect so many people. It's really incredible. Okay, so yeah, I'm going to talk a little bit about immunometabolism as a novel therapy. So next. Next. Okay, and I'm going to start just a little bit about the immune system in the gut and how they communicate and how we can use this communication to treat inflammation. So we know that there's a single layer of epithelial cells in the gut separating the bacteria from the host. We know that there's a lot of different kinds of immune cells, and we know that they communicate via cytokines. So a stimulus, a trigger, a message comes to a cytokine producing cell. They react in a certain way. They release cytokines. These cytokines then go to target cells, which have a specific receptor for a particular cytokine. And that target cell responds with release of more cytokines or some other effect. So next. So when we're talking about cytokines, there's a lot of different kinds of cytokines, and they can be pro-inflammatory, regulatory, or anti-inflammatory. And healthy individuals tend to have balanced levels of cytokines. So they have some pro-inflammatory and they have equal amounts of anti-inflammatory. But when we look at patients with IBD, they have more pro-inflammatory cytokines and reduced levels of anti-inflammatory cytokines. So this really drives inflammation. Next. So when inflammation starts, there's a danger signal, injury, infection, whatever the signal is, these cells release particular cytokines that are dependent upon what the signal is. Then, again, these cytokines bind to specific receptors and target cells respond. Next. And these target cells they stimulate other immune cells to release more pro-inflammatory cytokines. So it really becomes a cascade effect and a vicious circle that they continually drive inflammation. Next. So this is kind of our current model of how IBD progresses. So you have born with a genetic predisposition, and then there's some environmental factors. And this is really where the GEM project is focusing on what are these environmental factors and what are the triggers that really drive the onset of IBD. Because just because you have the genes doesn't mean you get IBD. There has to be a trigger, something in the environment to start it. And GEM has really shown that this loss of epithelial barrier integrity, so an increase in gut permeability, allows bacteria to come in. The bacteria come in, they interact with the cells of the immune system. The immune system responds appropriately and attacks the bacteria and causes inflammation. And then what happens is that the inflammatory process starts cascading and developing, and now you have subclinical inflammation. And it keeps getting worse, and that's when you have the uncontrolled immune response, and you have tissue damage, and that's when you have the clinical symptoms and or an IBD diagnosis. So next. So again, it progresses underneath from a normal anti-inflammatory environment to a pro-inflammatory environment to more kinds of cytokines which you can cause fibrosis. Next. So if we look at the current treatment for IBD, it's aimed at reducing inflammation. So there is the 5-ASA, the immunosalicylates, anti-inflammatory drug. There are the immunosuppressants, which suppress all immune cells, the steroids, which basically do the same thing. And then there are the biologic drugs. And these are the drugs that are selectively targeting specific pathways of the immune cells. Next. And one of the goals of these biological therapies are to rebalance levels of cytokines. Next. Okay, so if we look at how you can balance cytokines, if you look at a cytokine producing cell, you can either remove the stimulus, and this is where the GEM project is really coming in because they're showing what those stimulus can be, such as bacteria. So you can remove the stimulus if you know what it is. Or you can block cytokines from being made in the cell. Or if cytokines are still being made, you can block them, you can mop them up with an antibody. Or you can block the receptor on a target cell. So even if the cytokines are in the vicinity, they can't stimulate that cell. Or you can prevent that target cell from making more cytokines, or you can block the effect. Next. So the current biological drug approaches use all of these different methods. So there's drugs like Stelara that act to block cytokine receptors. There's drugs like the JAK inhibitors, which block the cells from actually making cytokines. Then there is the anti-TNFs, Humira, Remicade, which mop up TNF that's circulating in the environment. And then there are the lymphocyte trafficking blockers, which actually stop immune cells from coming into the gut. So all of these different drugs target inflammation at different points. Next. The unfortunate thing is not every IBD patient responds to every drug, as you know. So if we look at just the clinical response to primary TNF blockers, you get about a 45% clinical response. Unfortunately, up to 35% of those individuals will lose response over time, and another 20% show absolutely no response to TNF blockers. So we need new approaches. Next. And some immune cells can switch between being inflammatory or non-inflammatory. A T cell can be either inflammatory or non-inflammatory, and they can go back and forth. Same with things like a macrophage. They can either be inflammatory or non-inflammatory, and there's a switch. We can move them from one to the other. Next. And this is called metabolic reprogramming, because a cell needs energy to function. And interestingly, a pro-inflammatory immune cell uses one pathway of energy production, glycolysis, and an anti-inflammatory cell uses, it's called oxidative phosphorylation. And if you take a drug and change glycolysis to oxidative phosphorylation, you change that immune cell from being pro-inflammatory to being anti-inflammatory. Next. So there are drugs, metabolic drugs that do this. So translational immunometabolism means taking these existing drugs that are being used for other purposes and looking at seeing if they can be used for a new purpose. Next. So this leads me to SGLT2 inhibitors. So this is really a new approach for the treatment of inflammation in IBD. And you may wonder why I have a picture of kidney there. Okay, you will see shortly on the next slide. Next slide. Okay, so SGLT2 inhibitors, what are they? It stands for sodium glucose cotransporter 2. This is a protein that's found in high levels in the kidney. And what it does, it reabsorbs glucose. So you know that glucose in your blood is maintained at a stable level. So when the kidney filters your blood, it filters all the glucose, but then it reabsorbs glucose back into the system. And it does this through this SGLT2 transporter. So diabetic people have high levels of glucose. So this drug was originally designed to reduce glucose levels in people with diabetes. And what it does is it blocks the reabsorption, so glucose is filtered out and excreted in the urine. And these are the drugs that are commonly being used for this purpose: Jardiance, Farxiga, and Ivanka. Next. And interestingly, these drugs were first used and very highly effective for treating type 2 diabetes and reducing glucose levels. But in really large clinical trials, there was very unexpected findings that cardiovascular disease was definitely helped and improved with SGLT2 inhibitors. Renal disease as well was significantly improved in people on SGLT2 inhibitors. And further investigation in these large trials showed that these SGLT2 inhibitors had very strong anti-inflammatory effects. That this is a drug that is taken up and changes a pro-inflammatory immune cell from pro-inflammatory to anti-inflammatory. Next. And it was interesting that this was just presented at European Gastrointestinal Week. And they looked at people who had both IBD and diabetes. And they looked at how the diabetes was being treated in these individuals. And if the diabetes was treated with metformin or insulin, there's no effect on IBD disease. But if these patients with both IBD and diabetes were treated with SGLT2 inhibitors, they showed a reduced risk of escalating treatment for IBD. So it seemed to enhance the effect of IBD drugs in this population. Next. So looking at all of this, the question is, could we use these SGLT2 inhibitors in the treatment of IBD? They're commonly used, they're accepted, and they are showing great effects for cardiovascular, renal, and diabetes. So we decided to study this with the help of the Crohn's and Colitis Foundation. Next. So we are looking at this in several different ways. We're looking at animal models, trying to understand how these SGLT2 inhibitors could be used to treat colitis. We're looking at direct effects on these drugs with immune cells. And we're also looking at Alberta Health databases to see who's on these drugs and what is happening to them on the drugs. Next. So we've used several different models in animals. And the first model, we showed a large decrease in inflammation and significant improvement in colitis. And the model 2, it didn't improve colitis. And if there's no IBD, these drugs didn't do anything. So this is interesting because colitis is caused by different types of immune cells in these two models. So this is really helping us to understand how these drugs are working, how they're inducing anti-inflammatory immune cells, and where they best could be used in patients with IBD. Next. We also have looked at isolated immune cells. So we take blood samples from healthy individuals. We incubate them with these drugs. They don't do anything. But if we take these immune cells from IBD patients, so these are activated, they're pro-inflammatory, we incubate them with the drugs, and again, some of the immune cells, a certain kinds of them, will switch from a pro-inflammatory to an anti-inflammatory. So this is really showing us that these drugs are only working on activated pro-inflammatory cells. They have no effect on an anti-inflammatory or a regulatory immune cell. And in an animal model without IBD, nothing is happening. Okay, so next. And we've gone on to show that these drugs, these SGLT2 inhibitors, are directly affecting signaling pathways in activated and inflammatory immune cells to reduce cytokine production, to reduce proliferation. And it's doing this through altering cellular metabolism. Next. And in our database studies, we have shown, or we found, that there is 400 IBD patients in Alberta that are on both IBD medications and SGLT2 inhibitors. So we're looking at these patients, it's all anonymous, but we're looking at when they went on the SGLT2 inhibitor, what happened to their IBD after they went on it. And these are ongoing right now. Next. So overall, it's really a new way of treating inflammation by targeting immunometabolism. And this is really helping moving towards more personalized medicine. Next. In that drugs with different mechanisms of action are needed to increase efficacy of treatment. Because IBD, there's so many different kinds of IBD, so everybody's different, but it's helping that people with IBD donate blood samples, donate urine samples, donate stool samples. So we can look at their genetic background, what genes are being expressed, looking at their cytokine profiles, looking at their microbiome, and then being able to stratify patients and understand which is the best drug to treat that particular patient. And should drugs be combined, or maybe use one drug followed by another drug? So continuing to give samples to allow this kind of research to move forward is really helping to develop personalized medicine. Next. So really, we're moving, as you know, from one treatment fits all to more personalized diagnostics, where the right treatment, the right dose for the right patient at the right time for the right outcome is being developed. Next. And I just wanted to acknowledge the people in my lab, Crohn's and Colitis Canada, who I've been working with for at least 20 years now. I feel old, but it's been that long. And next slide, and I will say thank you and happy and sorry about the problems with the presentation, but I'd be happy to answer any questions if you have any.
Thank you so much, Dr. Madsen. So just as a reminder to folks, any of you, if you have questions, please feel free to ask them in the chat box, and we'd be happy to ask them to Dr. Madsen. Maybe we'll just give the folks a few minutes. I'm sure they were engrossed in your presentation as I was and trying to digest your materials. In the interim, I'd like to ask you a question. I mean, it's exciting that you're trying to repurpose a drug, and would this mean, since you're repurposing a drug instead of using something that's you're trying to make from scratch, would this mean it would be faster to come to a clinical practice?
Absolutely. Because it's already approved, it's in use. I mean, IBD patients are on it. So therefore, it would be very fast to come into clinical use.
How can you, like, just for the audience sake, what would be the timeline in terms of, let's say everything goes smoothly for you, Dr. Madsen, with your research and all of that, what would you say might be the timeline?
Yeah, that's a really good question, because we have started conversations with the drug companies that are making this drug, and showing them that it could be effective and getting their support. And obviously, one of the problems is they don't want to move into IBD because they already have it working for these other conditions. And they're worried that, what if it doesn't work? But as our research continues, we go to them and say, listen, this is working. We're showing that it works in IBD. So let's try a clinical trial. So if you look at a normal drug pathway, that can take, 10 years. If we look at repurposing a drug, it can be 1 to 2 years.
That's
so
fantastic.
much quicker.
Oh, wow. Okay. That's very encouraging. Thank you. So we have a question from the audience. It's from Alia, and she's asking the SGL2, since can it only be used, I guess this relates to the question about personalized medicine. Can it only be used for people who have diabetes and IBD?
That's currently what it is being used for, but that's kind of the goal of our research, to show that it could be used alone in the treatment of IBD, and it could be effective in certain kinds of IBD. So that's what we are moving towards.
Okay, and another a related question from Rhonda, just maybe perhaps you could clarify what was the medication being used for in diabetes?
Yeah, so they looked at all patients, and they looked at all the different medications they were on. And if they were on the metformin or insulin, it didn't affect the IBD at all. But if they were on the SGLT2 inhibitors and the DPP, I think, inhibitors, they did show a very much enhancement of the IBD drugs. So again, it's not simply treating diabetes that helps the IBD. It's the particular drugs that are being used to treat diabetes that has this additive effect.
Okay, thank you. So unfortunately, we're out of time. So we're going to have to move. Oh, one more? Okay.
I just want to do one more question. Glucose levels be affected? No, and that's a really exciting part that we have found, that if you take these drugs, we showed that in our animal models as well, if you don't have IBD, it does not affect glucose levels. And that's what they're finding. They're using these drugs treating cardiovascular patients and renal patients who do not have diabetes. does not affect glucose levels if you don't have diabetes. So that's a really
Interesting.
exciting thing about these new drugs.
So with that, very cool. I agree with you, Tharmia. Does that mean that if people who, as you know, malabsorption is one of the symptoms, and so meaning that they aren't able to absorb enough nutrients, they may be losing weight and so forth. Is this something that could possibly be used for such patients as well?
Difficult to say. We'd have to do more research to really answer that question.
Okay, fantastic. Thank you so much, Dr. Madsen. We are now going to move on to our next two guest speakers. We'll be hearing from Dr. Juan Nicolas Peña-Sánchez, who is here with Ms. Rhonda Sanderson, a patient partner. A reminder to put your questions in the chat, and I see some of you have been doing that, so thank you for that. And if we don't get around to your questions, again, a reminder, please feel free to send your questions to volunteer@crohnsandcolitis.ca, and we'd be happy to follow up with you with the answers. So introduction of Dr. Peña-Sánchez. So Dr. Peña-Sánchez is a faculty member in the Department of Community Health and Epidemiology at the University of Saskatchewan School of Medicine. His collaborative and interdisciplinary research programs aims to study and promote innovative healthcare approaches that addresses the needs of minority populations and overcome the challenges of healthcare systems. Dr. Peña-Sánchez is one of the members of the Inflammatory Bowel Disease Research Collaborative Network. In partnership with Indigenous patient and family advocates, he has been working on raising awareness about IBD among Indigenous peoples and advocating for better access to IBD care and their well-being. As an investigator of the Canadian Gastrointestinal Epidemiology Consortium, or CanGEEC, Dr. Peña-Sánchez is the Saskatchewan lead of collaborative IBD national studies using administrative health data. Ms. Rhonda Sanderson is an Indigenous Cree woman from Jane Smith Cree Nation. She was diagnosed with IBD in 2001, although she believes her disease started during her childhood. Ms. Sanderson was a child growing up in a residential school where her gastrointestinal issues were neglected. As an adult, she was exposed to misconceptions of healthcare providers about IBD among Indigenous peoples. Ms. Sanderson was diagnosed with IBD after she went through a non-indicated appendectomy. She also has experienced barriers to accessing gastrointestinal care and became a self-advocate to accessing appropriate care after years of struggles with her disease. Sorry to hear that, Ms. Sanderson. So with that, over to you, Dr. Peña-Sánchez and Rhonda.
Good morning, everyone. Thank you very much, Kate, for that introduction, and thank you, Rhonda, for being here with me to co-present, and thank you again for the invitation. It's wonderful to see so many names and faces of volunteers doing wonderful work in Crohn's and Colitis Canada. Can you see my screen? Jessica, okay.
It's not in presentation mode, though, Juan Nicolas.
That's right. What about now?
Yes, it is.
Okay, and you can see the full screen. No, my notes. Good. Technology. Well, thank you. So, as Kate introduced us, my colleague Rhonda Sanderson and I are here on behalf of our team. So that's something that I want to acknowledge. We come representing a full group which has been working on this field, and we're excited to share about our journey and results. I'm happy to hear your comments and questions. So, Rhonda, I'll pass it to you.
Good morning. Tanse Kanaskomiten. I'd like to do the land acknowledgement. As we gather virtually here today, we are on Treaty 6 territory and the homeland of the Métis. We acknowledge that they are meeting participants connecting from other treaty lands and unceded lands across Turtle Island. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Denige. The outline. Here's what we are presenting on. Here's the outline, and there is no conflict of interest. Next. The introduction. Inflammatory bowel disease, IBD, is a chronic and relapsing and remitting disease of the gastrointestinal tract, ulcerative colitis, and Crohn's disease, where sections of the GI tract becomes inflamed and ulcerated. The exact cause is unknown. Studies suggest an association with urbanization, modernization, and Western diet. Okay. Canada has one of the highest numbers of people living with IBD and diagnosed with IBD. About 400,000 people will live with IBD in Canada, and it's an approximate 1% of the Canadian population, and over 11,000 Canadians will be newly diagnosed with IBD in 2023. Wow. Okay. Patients living with IBD will require lifelong health care. IBD has potential to cause significant long life morbidity, life-threatening diseases, direct health care cost, reduction in health-related quality of life, loss of working and productivity, and poorly controlled inflammation leads to complications for hospitalizations and surgery.
Thank you, Rhonda. So many of these points maybe came to your attention before, and this is evidence that has been built in the general population. However, at one of the Crohn's and Colitis Canada meetings, came to our attention questions about if we knew any of these results, any of this piece of information about the number of people living with IBD, or what happens on experiences of indigenous peoples with IBD. At that moment, for example, I didn't know anything about it. So a couple of research team members and I started looking at the evidence, and we found, interestingly, that in the very limited to no evidence was available about what happens with IBD when talking about indigenous peoples in Canada, specifically First Nations, Métis, and Inuit, and around the world. But very few studies have been published until 2018, when we decided to come together as a group and work in this field. In addition, it was clearly understood in the literature that indigenous individuals have lower numbers than the general population, but it doesn't mean that they didn't exist. And here is where the voices of indigenous individuals living with IBD have a very important piece in the story. Furthermore, it is well known and documented that indigenous peoples face additional barriers to access healthcare, including consequences of colonization, stereotypical perceptions, as well as barriers due to communication or language, barriers due to transportation, the place where they live, among others. Now, when we connected with people like Rhonda, wonderful people like Rhonda and other colleagues in our research team, we started hearing very interesting narratives that provide the foundations of why we needed to start this work. So Rhonda, if you want to share your lived experiences.
Yes, living with Crohn's disease, I was diagnosed in 2001, like was previously mentioned. I had an appendectomy, and the surgeon after my surgery told me that they had found something wrong. They did the biopsies and he diagnosed me with Crohn's disease. At that point, I had no clue what Crohn's disease was. I thought it was an old person's disease. The surgeon then told me that I was old to be diagnosed with it. And I was like, wow. So I had issues right from the get-go. And I was referred to a gastroenterologist 2 hours away. And my first meeting with that gastroenterologist, he just bluntly told me that indigenous people don't get Crohn's disease, and he didn't think that that's what I had. And I thought for a moment there, oh, great, I don't have it. And then after he did the colonoscopy, I was re-diagnosed with Crohn's disease. And I was amazed that somebody could just take one look at me and say, you can't have that. And a lot of times I was traveling 2 hours away to see a gastroenterologist, and I really had to advocate for myself. I had to talk to my general practitioner and told him I wanted a new gastroenterologist and to refer me to the IBD clinic at the RUH hospital in Saskatoon. So I convinced another doctor to refer me, and I got referred to the IBD clinic in Saskatoon, where I met Dr. Cheryl Fowler, who spent over an hour with me and my husband talking about my disease and what treatments are available and the medication that I'm on. And I've always had to educate people about my medication because one of them is Immurant or Zyothioprine, and it's used for anti-rejection in organ transplants. And they always ask, why are you on this? And I always have to tell them, I have Crohn's disease, and that's one of the medications they use. So I've always had to educate nurses, doctors, my general practitioner. It was always me advocating for myself. This is what I have. These are what the medications are for, and this is how they work. And it was a big, big learning curve for me and how to advocate for myself, for my disease. And it's turned me into a really great advocate for my family. My children have gotten sick and have showed signs of Crohn's disease. And I'm always telling the doctors, do you think maybe it's Crohn's? And well, they have to have a family history. Well, they do. I'm their mother. I have Crohn's disease. And maybe this is where you need to be looking. But had I not had Crohn's disease and my children were symptomatic, they wouldn't be looking for Crohn's disease. So it's amazing how much I've had to educate people in saying, I have Crohn's disease, I am Indigenous, I am a human being, please help get me well. And that's the basis of my relationship with my doctors and my gastroenterologist. I just love my gastroenterologist because she answers all my questions and she takes really, really excellent care of me. So I'm very grateful for that. Thank you.
Thank you so much, Rhonda, for sharing your story. Now, Rhonda and I wanted to share the stories of another couple of colleagues. First, I invite you to hear Linda and Robert Porte's story. I think the sound, I will improve the sound, just a second. And Jessica, feel free to just say if the sound is not loud enough.
I'll let you know if it works.
Thank you.
And thank you for sharing, Rhonda. Yeah, just like Chantel is saying in the chat, that I really appreciate you sharing that, and I'm sure everybody enjoyed hearing. It really breaks our hearts.
Okay.
Hi, my daughter is Lisa John, and we are the parents of a daughter who fought a battle of Crohn's disease half her life. We've seen her in pain half her life. We've seen her go once or twice a month, go to emergency. She was in and out of hospitals, and we watched her go from a vibrant young woman to only being a shell of a person. In the end, we have been to many hospitals in Saskatchewan, Alberta, spending many hours visiting her and having good and bad experiences with healthcare professionals. In the end, she had many nurses that loved her at St. Paul's Hospital. She was only 32 years old, and it still hurts knowing she is gone. Thank you.
This is my daughter, Lisa, a young Aboriginal woman taken from her family far too early as a result of the long-term effects of Crohn's disease. We have been recently made aware of that until recently that IBD was believed not to be an issue with Aboriginal peoples. Her journey began at the age of 13 and took her through many facets of our Canadian healthcare system. Some good, but for the most part, it was a journey of misunderstanding, underinformed, and to be honest, complete ignorance for the course of treatment for this sinister disease. Some of these images I hope to convey what we saw as a family as part of this journey. The desperate hope for a possible life-changing solution, the despair and loneliness that one may experience when trapped in the brain-numbing cycle of doctors, nurses, ER waits, hospital rooms, and the always present pain involved with bowel disease. Lisa's journey came to an end on her 32nd birthday, and my mission as her father is to continue her story, to try to help improve the understanding that IBD is more prevalent in Aboriginal communities than it was first believed, and in society as a whole. Also, to improve the conditions of a patient and their families in regards to the treatment from some of the medical professions, as there's a gap in the empathy levels with some of the professionals, which may be a result of lack of knowledge. So in conclusion, I want to be her voice to continue her fight to make a difference and assist patients and their families dealing with IBD.
Now, before we start talking about our work, I wanted to share, Rhonda and I wanted to share the story of Colton Brass.
I am an Indigenous person that was going to school while these symptoms occurred. 1 month before my initial diagnosis, I had been feeling the symptoms of Crohn's disease. Symptoms such as upset stomachs and fatigue. These symptoms persisted and did not go away. 2 weeks before my initial diagnosis, I went to a walk-in clinic. I talked to a physician and I explained my symptoms to them and how they have been getting worse. I explained to them what I've been going through. I wrote down a list and told them. They told me to eat better and drink liquids to recover my electrolytes. They didn't prescribe me any medications, nor did they do any tests. My symptoms were not getting better, only worse. 5 days before my diagnosis, I went to see my family physician. I gave them a list of my symptoms. I told them about everything. I was then provided medications, which I feel would have made my symptoms worse. I wasn't being listened to, nor was I being taken seriously. The day I went to the hospital, I was diagnosed with Crohn's disease. I had to go to 2 different hospitals for various testing. And today I am going through treatments that keep my symptoms under control, and my gastroenterologist keeps an eye on my symptoms. I can say that I'm getting the care I needed now, but things could have been significantly different if I was taken seriously a month before my initial diagnosis, when I was feeling these symptoms mildly.
I want to thank for Rhonda, Linda, Robert, and Colton for sharing these experiences. And I know these stories might generate some reactions and trigger some emotions. So thank you for listening. And this is why these narratives, these stories, moved us to bring together an interdisciplinary research team, which has in the center Indigenous patient and family advocates, like people like Rhonda, Linda, Robert, and Colton. And this research team has in the core their voices, their advocacy, working with Indigenous and non-Indigenous health researchers like me, and knowledge users, including a gastroenterologist, including epidemiologists working with the government, a representative from Crohn's and Colitis Canada. And we as a team, within this framework of the medicine wheel, we move the wheel towards advocating for for better health and well-being among indigenous peoples, and the name is Mayomasha Win, the Cree word for good health and well-being. So, and now I will pass it to Rhonda, and she will outline the aim of each of the projects that we're going to share within the next minutes. Rhonda, you're muted, just in case.
There we go. Our study and results aim to raise awareness of IBD among Indigenous people and advocate for a better healthcare and Mi'kmaq. Estimated the province in the incidents and trends over the time of IBD among First Nations in Saskatchewan, compare healthcare utilization, visitation between First Nations individuals with IBD and with those in the general population, explore the predictions about IBD and the barriers and facilitation to access healthcare among Indigenous people, immigrant and access, peer IBD patient navigator program to assist, support, and guide Indigenous people living with IBD. And I think it would be the most helpful to have somebody of like mind to speak to you when you're first diagnosed.
Yes, so these are the 4 research questions that we frame, and we are going to show you now the results. So for answering these research objectives, we have been using quantitative and qualitative research method. That means using numbers and narratives, and as well practicing some knowledge to action. So not only generating research results and publications and presentations, but creating changes in the healthcare system. So the first one, to talk about the epidemiology, that means the number of people newly diagnosed with IBD, specifically among First Nations in Saskatchewan. So for doing this study, we use administrative databases. That means that every time you go to a physician visit or a hospital, there is a record about this interaction. And the Ministries of Health have these databases, and we access them to evaluate this specific study objective. First, with using these administrative databases, we were able to determine how many First Nations in Saskatchewan are living with IBD. That's known as the prevalence. And we found that since 1999 until 2016, the number of First Nations living with IBD was increasing. Very similar, and that applies for both ulcerative colitis and Crohn's disease. A very similar trend that was reported in Canada for the general population as well as for Saskatchewan. In addition, the number of individuals who get the diagnosis of IBD every year has been stable over the last 20 years, being around 1 person, 11 people per 100,000 population. So that means around 18, 20 people with the First Nations with a new diagnosis of IBD every year. And and when you compare these trends, they differ with the general population. They are in agreement and differ at the same time. So the number of people living with IBD is actually increasing, very similar to the general population, no difference. So more people is having the disease and coming together in this group. And the number of newly diagnosed people, in contrast to the general population, we have been observing a decline during the last years. There was some kind of a stable plateau, and now it's decreasing the number of new people with diagnosis, but among First Nation is quite stable. There are no changes over time. So there are the differences. In addition, as Rhonda's story, First Nations individuals with IBD tend to be a little bit older than in the general population. So maybe it's not because they develop the disease later in life, it's because it takes more years to get access to care and get access to the diagnosis, likely. There is a higher proportion of First Nations living with IBD in urban settings, just like in general population. Although we found something interesting, the proportion of individuals with ulcerative colitis and Crohn's disease is inverse than in general population. There are more First Nations living with ulcerative colitis than with Crohn's disease. In contrast, in the general population, we see more people with Crohn's disease than ulcerative colitis. And to highlight, this work was completed with Rhonda and other indigenous patient and family advocates. The second study that Rhonda mentioned, we wanted to compare healthcare utilization between those that are First Nations and those who are not, the general population. And this is because we hear voices like Rhonda that there are concerns about accessing to care. So we use, again, these administrative databases to compare going to the gastroenterologist, number of visits to a gastroenterologist, number of hospitalizations, number of medication claims, and so on. What we found was that in First Nations living with IBD in Saskatchewan had fewer medication claims for IBD, like biologics, immune modulators, 5-SA, than the general population. At the same time, we saw that First Nation individuals with IBD had a higher risk of hospitalizations than those in the general population. What can we see with this comparison? That maybe First Nations are observing or experiencing barriers to access to specialized care, getting medication prescriptions, be able to claim them, take them, and prevent them to be in the hospital. So because they don't have this outpatient care as in the general population, they end up having more hospitalizations than those in the general population. These results are talking about those barriers that have been described in other healthcare conditions and how important it is to make changes in our healthcare system. Again, this was a work completed in close collaboration with the indigenous patient and family advocates. Another study using qualitative methods and non-colonized methods that is called photo voice. It means narratives, stories. We gathered the voices of indigenous peoples living with IBD to understand what IBD means for them, what helps them access, what are their expectations, what are their barriers. And this is a study that we recently concluded. We are completing the data analysis right now. What I can tell is that this decolonized method helps asking people like Rhonda, what is IBD for you? Or what are your expectations to healthcare? As an example, one of the study participants took a picture of an end of the road where you can see a yellow arrow, go to the right, go to the left. And the presentation of this person with IBD was that the person was able to see a green grass behind the two options that the road is offering. And it was quite interesting because myself, a colonized approach will be to see you have the offer to go take this medication or go for surgery, but this person was seeing a full range of options behind those two pathways. And we hope to share and publish these results and share them in further meetings. Now the knowledge to action phase. So this is a new initiative that we are working with people like Rhonda. And Rhonda, I'll let you share more about the Indigenous Peer Navigator initiative.
Indigenous and patient family advocates are the navigators of the IBD IPN program. The program is developed in collaboration with the Saskatchewan Multidisciplinary IBD Clinic. Patient navigators will help build relationship and trust and have one-on-one meetings. They'll guide patients through the healthcare system, and we can make recommended reliable sources. We facilitate communication between patients and healthcare providers, advocate for health and well-being of Indigenous IBD patients living with IBD. And I think it would help newly diagnosed patients to have a patient navigator meet with them one-on-one to help them.
Thank you very much, Rhonda. So this has been our journey. This is the framework that we started in 2018. This has been some of our achievements. We determined the number of people, First Nations with IBD in Saskatchewan. We hope to do it in other provinces as well. We identified barriers and inequities, accessing care. We explore barriers and facilitators through the photo voice study. We are co-developing this peer IBD Indigenous Patient Navigator program in Saskatchewan, and if successful, be implemented in other provinces. And we are contributing to a national training network called Triangle. So in conclusions, In comparison to the general population, the total number of First Nations with IBD and the number of newly diagnosed individuals with IBD is lower than in general population. However, the rate of increase that we're observing among First Nations in Saskatchewan is a little bit higher than the general population. And we are seeing more people with ulcerative colitis than you see when they have First Nation background. First Nations with IBD diagnosed with IBD experience barriers to access specialized care, which we can see in lower medication claims and higher risk of hospitalization. And recently, the IBD Impact Report highlighted these results, and Crohn's colitis is calling for further research and initiatives to improve the care and well-being of First Nations individuals and Indigenous peoples in across Canada. Rhonda.
Conclusions and recommendations. These patient-initiated and driven research initiatives can challenge potential misconceptions, increase knowledge of Indigenous patient needs, advocate for well-being among Indigenous patients with IBD in their communities, identify the barriers and facilitators to deliver culturally appropriate IBD care. This model and research experience could guide future research initiatives.
Well, thank you very much, all of you. We acknowledge our funding organizations and members of the team. We will be happy to hear your comments and questions.
Thank you. My goodness. Thank you to Rhonda, to Colton, and Lisa's parents.
Rhonda.
I have to say, Rhonda, it broke my heart to listen to your story and everyone's story, to see this, to hear about your personal experience with this. Good for you that you were able to advocate for yourself, and really happy to hear that you eventually found a good gastroenterologist who could help you. Dr. Peña-Sánchez, thank you so much for this important research as well, and working with the First Nations. Just to let the audience know, Dr. Peña-Sánchez is really in our IBD community, research community. He is our leader when it comes to determining and understanding better IBD in the Indigenous population. So thank you for your leadership in that. And you play such an important role in our Impact of IBD report, just to at least shine a light in it, and to really talk about how little we know right now. And I have so many questions, but unfortunately we're out of time. I've been advised by Jessica that we're over time, but such an important story and such an important presentation. So thank you to both. And please pass on our thanks to the other folks who weren't able to join us in person. So thank you so much.